Fehlings?
Okay, I will share.
Hello, Dr. Michael.
The voice is not coming.
Okay, I'm checking again.
If it's an issue with technical reasons for the video, I could present live if that works. I can do that as well. Okay. Hello, I'm Michael Fehlings from the University of Toronto, and it's a pleasure to take part in this WFNS webinar. I'll be speaking on the concept of timeless spine and making the case for early surgical intervention in acute spinal cord injury. I don't have any relevant commercial disclosures. I have founded a regenerative medicine spin-off from my lab called IntelliGex, but I won't be discussing any of that technology today. And I also wish to acknowledge a number of sources of funding support, which are listed on this slide. I wish to thank Mehmet Zaleli for his wonderful leadership in putting together these WFNS educational symposia. And I also wish to acknowledge the esteemed speakers that are taking part in this symposium as well. So I'll be discussing the rationale and the evidence for early surgical intervention for spinal cord injury. I'll discuss the current AO Spine guidelines, and then I'll present novel data on the role and timing of surgical intervention for acute spinal cord injury. And this will give a snapshot preview of the new AO Spine Praxis guidelines, which have just recently been published in the Global Spine Journal in 2024. And then I'll also discuss the evidence for central cord injury and Asia A spinal cord injury, because these are sometimes controversial topics that come up, and I'll make some conclusions and take-home messages. So when one considers the pathophysiology of spinal cord injury with a primary mechanical injury that is amplified through the processes of secondary injury, it makes sense to consider the potential role for a surgical intervention. And the idea here is to try to attenuate the impact of secondary injury mechanisms, including ischemia, inflammation, release of free radicals, and so on. And the basic concepts here in this patient who has a bilateral facet dislocation of the cervical spine with open reduction, internal fixation, and decompression of the spinal canal. And this is supported by a wealth of preclinical data, beautifully summarized by this elegant meta-analysis by Peter Batchelor. And in essence, these animal studies show that there's about a 35% improvement in neurobehavioral outcomes with early surgical intervention. And remarkably, this is actually roughly paralleled by the effects that we see in the clinic. So the STASCUS study was really the first high-quality prospective study to give a sense that there was an important positive effect by early surgical intervention for acute traumatic spinal cord injury. This is now published over a decade ago. And just by refresher, this was a prospective a study done in 6 centers in North America through the Spine Trauma Study Group, over 300 patients were enrolled with cervical spinal cord injury. And in a nutshell, in patients who had surgery within 24 hours, and this was at a median time of 14 hours after a surgery, we saw that the odds ratio of patients having a 2 or more grade change in their Asia impairment scale with early surgical intervention was almost threefold higher. This was a very large treatment effect, and this had a significant impact on standards of care around the world. This and a number of other studies evolved, and for the first time, we were able to issue recommendations that surgery was the preferred option for acute spinal cord injury, and that this was best done within a 24-hour time frame. Because of the paucity of studies, however, and the variability in terms of how outcomes were assessed, it was not possible to do a quantitative meta-analysis, and hence the recommendations were somewhat tempered. This really prompted us to do the following study that was subsequently published in Lancet Neurology. And this was an individual patient meta-analysis from a number of prospective studies. And this included over 1,500 patients with acute traumatic spinal cord injury. And these are two of the key figures from this paper. On the left, we are plotting the changes in the motor scores as a function of time. The red dotted line represents 24 hours, and one can see that there's a clear dose-response relationship between a neurologic benefit and the timing of surgery. And in this histogram, we've plotted the changes in motor scores, again, as a function of time, and we see that the peak benefits are observed within 24 hours. This, in a number of other studies that were published subsequent to the 2017 guidelines, prompted us to issue a new set of guidelines that were just published in the March edition of the Global Spine Journal. And to date, this is the most comprehensive updated review on the timing of surgery for a spinal cord injury. And we use the GRADE approach for evidence synthesis. So this is one of the meta-analyses that was done. And this is the forest plot showing the recovery of 2 or more grades of function on the Asia impairment scale at an earlier time point at 6 months and in a longer term a time point. And we again see on this logarithmic plot results that are reflective of the original Staskis results. So about a 2 to 3-fold higher odds ratio of getting a 2 or more grade change in the Asia impairment scale with early surgical intervention. We also were able to quantify the motor scores using the Asia standards, and we see here that there was about a 4.5 motor improvement with early surgical intervention. And if this is potentially translated in terms of hand and upper extremity function in a quadriplegic individual, this can have a pretty significant effect in terms of their quality of life. Importantly as well, early surgery is safe. Complication rates are not increased, and if anything, there is a reduction as illustrated here in this forest plot showing mortality rates, which does not meet the level of significance, but it's very close to trending toward a reduction in mortality rates with early surgical intervention, strongly suggestive of the safety of this intervention and the fact that certainly complication rates are not increased, and if anything, there are trends toward reduction in complications. So based on this evidence, there is now a strong recommendation that surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours after injury when medically feasible. And this is important because there clearly is a lot of judgment that is required. So for example, some patients are medically frail, some patients have a multi-system trauma, and here one may not be able to intervene within the 24-hour time frame. And these guidelines allow the medical teams the leeway to exercise judgment in these cases. Now, what about the ultra early time point? And here we've defined this as within 12 hours for acute spinal cord injury. So it makes biological sense. There is some emerging literature support, as suggested by this article from the UCSF group. And certainly if we look again at our article from the Lancet Neurology, we see this dose-response relationship suggesting that potentially earlier time points of intervention, when feasible, might be associated with benefit. Now, importantly, right around the time where our guidelines were issued, this paper, the SkyPome study from the European group, was published. And this was a study examining ultra-early surgery versus more delayed interventions. And these authors compared an ultra-early time point of less than 12 hours versus a combination of early and delayed surgery. And one of the challenges that these authors ran into was that because of the shifts in standards of care and care pathways, most of the patients in the delayed group actually had early surgical intervention. And so the differentiation between
Dear Michael, actually, we could not solve that blurring vision. It may be better that you continue from your own slides. Is it possible?
Yes. Can you enable me to have screen sharing, please?
Yeah, I will. Now you can.
Okay. Yeah. Thank you.
I thank you, really. Sorry for that. I don't know the reason.
Are you able to see my screen?
Yeah, yes. Yes, it's okay.
Perfect. And you can hear me okay? Video is all right?
Yes, Professor.
Thank you.
Yes,
Okay.
yes, Michael.
So I'll go over
Please.
these slides quickly and then I'll kind of resume. But I realize that people may not have seen this, and apologies for the challenges. But you know, I've been asked to kind of present the current arguments related to the role of surgery and the timing of surgical intervention. I have no relevant disclosures, and again to thank Mehmet and to acknowledge the esteemed team of colleagues. So I'll be talking about the rationale and evidence for early surgery, and I'll be focusing kind of on the evidence underlying the current AF spine guidelines. And then I'll talk about some of the controversies in knowledge gaps, and then also present some of the evidence around central cord injury and some take-home messages. So, you know, the concept of early surgical intervention is really based on the idea that the primary mechanical injury is amplified through the processes of secondary injury, and the compression of the cord and the ongoing instability in the spinal column enhances secondary injury. And so the idea, which is really based on sound science, is that early surgical intervention would be beneficial. And I think one of the challenges has been the implementation of this, but with the advances that have occurred in surgical technique, anesthetic management, ICU management, and so on, we've now seen that, you know, that this is a reality that we can try to implement. And this is supported by strong basic science evidence, as shown by this elegant systematic review and meta-analysis by Peter Batchelor, showing around a 35% improvement in effect size in animal models, ranging from small animals to primates, with early surgical intervention. And interestingly, this is largely reflected in the improvements seen with surgical intervention. So again, by review, the STASCUS study, 313 prospective patients in North America through the Spine Trauma Study Group. And in a nutshell, we found that patients undergoing surgery at a mean time of about 14 hours after injury, but within 24 hours, had a almost threefold odds ratio increase of having a 2 or more grade change in the Asia impairment scale after spinal cord injury. So this study had a big effect worldwide on kind of standards of care and care pathways. And then based on this, the first set of guidelines emerged in 2017, suggesting for the first time that early surgery for acute traumatic spinal cord injury is the preferred option. So the level of evidence here was lower than we would have liked. This is the stringency of the grade guidelines, largely because there weren't a lot of other studies that we could combine with STASCUS, and so we were limited in terms of the quantitative meta-analysis that can be undertaken. So as a result of this, we were kind of inspired to undertake this large study, prospective study published in the Lancet Neurology, over 1,500 patients with all severities of traumatic spinal cord injury. And in a nutshell, we found quite compelling evidence in favor of early surgical intervention for acute traumatic spinal cord injury. So on the left is a graph highlighting the changes in the motor score as a function of time, a very clear dose-response relationship. And we see this red dotted line is first 24 hours. So we see quite a marked effect within the first 24 hours. And this histogram has plotted the changes in the Asia motor scores as a function of time after surgery. And again, the best outcomes cluster within this first 24-hour time period. So based on this, and a total of 21 studies that we were able to include, we were able to use a great approach for evidence synthesis and to formulate new clinical practice guidelines. And these have just come out in the Global Spine Journal. And as shown here in this meta-analysis, we see quite significant, statistically and clinically significant improvements in outcome at 6 months and at 12 months. And we see improvements in motor scores, as well as a major increased likelihood of a 2 or more grade change in the Asia impairment scale with early surgery, essentially validating the results of the STASCUS study. And this shows the changes in the motor score. So on average, around 4.5 changes, motor point changes. And again, with a patient who's tetraplegic with a cervical injury, this would be quite an important effect. And again, the surgery is safe. Mortality, if anything, has a trend to reduction. And so we now have a strong clinical practice guideline. Surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours. Now, when it's medically feasible, and this allows the medical teams leeway to exercise judgment in patients that are medically frail, older, medical comorbidities, the setting of polytrauma, and so on. And it's also recognized that there's substantial logistical challenges, sometimes with the transport of patients to get there in the first 24 hours. And this kind of brings forward the challenges in the implementation of these guidelines. Now, what about ultra-early surgery, which we've defined as less than 12 hours after acute spinal cord injury? And it makes biologic sense. There's nothing inherently magic about the first 24 hours as a cutoff. It's that this is logistically feasible. It allows teams to stabilize the patients. And this is one study from UCSF's providing data to suggest enhanced recovery with ultra-early surgery. And this is also reflected again in our Lancet Neurology article, where again, this dose-response relationship between the timing of surgery and optimal outcomes, with the optimal period being within this 24-hour period. Now, this is the SkyPoem study that was published just as we are completing the guidelines development process, and we do make reference to this article in our Global Spine Journal. And essentially, this was a study done in Europe where they were examining ultra early surgery within 12 hours versus later surgery. And one of the logistical challenges that these authors ran into was that there was a shift in essentially standards of care in Europe. And most patients in the delayed group actually had surgery within 24 hours. So the difference between this ultra early group and the delayed group was actually quite narrow. Having said that, the unadjusted analysis did point in the direction of enhanced lower extremity motor scores with ultra early surgery, but there's some technical challenges. There were some baseline differences between the two groups, which were challenging to balance, and there was some loss to follow-up. So I would say that this study right now is inconclusive, but it does point in the direction of a potential signal for ultra early surgery. So it makes biological sense, but further evidence is going to need to be required. And now, importantly as well, what about patients, let's say, with a cervical ASIA A injury? And about 44% of these patients will shift their ASIA motor scores and ASIA grades with early surgery. But what about when they don't? Is early surgery still worthwhile? And this is a very nice article from Valerie Terwengel in the Netherlands that we were part of. And essentially, Valerie showed that early surgical intervention in patients with a motor complete cervical injury is associated with a gain of 2 or more motor levels. So for example, let's say like a C5 patient going to a C7 level. That's a big effect in a tetraplegic individual. And then what about central cord injury? And I present this case of a patient with ossification of the posterior longitudinal ligament. And the nature of my practice in Toronto is that it's an extremely multicultural center, and we actually have a high Asian population. We see quite a bit of OPLL and central cord injury, and this is actually becoming the commonest form of spinal cord injury that is being seen in high-income countries as well. This issue is becoming more important. The global burden of traumatic brain and spinal cord injury remains high, and we're seeing a shifting demographic where we're seeing older patients, more fall mechanisms, and more cervical injuries. So this was a propensity-based prospective study, which we published in JAMA Surgery about 1.5 years ago. 186 patients with central cord injury, 93 early within 24 hours, 93 delayed surgical intervention after 24 hours. And the overall results did show a favorable benefit of early surgical intervention with improved motor scores. But when you drill down and you look at, let's say, more severe injuries, ASIA C, versus milder injuries, ASIA D, the predominant benefits are seen in the ASIA C more severe injuries. Now, could there be a benefit in the ASIA D population? There could be, but we need to have more sensitive outcome measures to detect this. And so the conclusion from this paper was that early surgical decompression for severe ASIA C central cord injury was associated with neurologic benefit, and we need further data, I think, to make judgments on the ASIA D patients. And the technique of surgery matters. Surgery has there's a significant art to doing this. Bijan Arabi's work points to the fact that the quality of the decompression is probably just as important as the timing of intervention. And there's new techniques that are evolving, so the potential use of expansile duroplasty is under investigation currently in the UK by Papadopoulos's group. So take-home messages and future directions. Surgical decompression for cervical and thoracic spinal cord injury within 24 hours of acute spinal cord injury improves neurological recovery. And the 2024 AO Spine Praxis Guidelines, which have now been published in the open access in the Global Spine Journal, does make a strong recommendation for surgery as soon as possible within 24 hours, regardless of level of injury. Now, having said that, there is leeway, of course, to exercise medical judgment, and for the reasons I've indicated: medically frail patients, patients with polytrauma, sometimes when there are delays in the transfer of patients, and so on. There's nothing magic about the 24-hour cutoff, and time is fine. The timing matters. So in a young person without medical comorbidities, I think that ultra-early surgery makes sense, especially for an incomplete cervical injury. But as always, there's a lot of judgment that's required. So on that note, happy to close. Sorry about the technical issues with regard to the to the video, but fortunately I was able to present this live as well.
Thank
Great
you.
talk, really. We enjoyed it a lot. And now, Sergio, you can moderate the questions, discussion.
Yes, yes, Professor Zeriali. Any questions? No hands raised. I think the 4 presentations were very rich.
There was a couple of questions.
Sergio,
Yes, yes, Professor.
I'd like to.
Oh, sorry. Go ahead, Jody. I was just going to comment on questions in the chat, but please go ahead.
Yeah, I think we go with the same line that this ultra early surgery is very interesting. When we were thinking about the first 4 hours of the injury before they go in for the secondary injuries to take place, if you look at all the research, also says that everything done very early actually improves the patient, particularly in incomplete injuries. So my feeling also same. The last point which you made, Michael made, was absolutely very important because many times the incomplete injuries showed one patient also. You can see that incomplete injuries they are more likely to improve very well with early surgery. But only thing is that when the patient comes to us, we do not know, depending on the place where we practice and the type of the places where the facilities are available to, or the patient is very close by to your hospital who reaches very early within 4 hours or 2 hours time. And provided they are isolated spinal cord injury. So it's very interesting point because I also compare the same thing with the infusion of methylprednisolone within that short period of time, 4 hours. There is always a point of discussion for incomplete spinal cord injury. I think Michael, I would like to really want some of you can throw some light on that when comparing this ultra time surgery and also the application of MPSs in a very short time, that is within 4 hours. So that point seems to be very interesting. Both surgical decompression and at the same time, the effect of methylprednisolone, which we found very useful in the laboratory.
Okay, thank you. So maybe I'll address the 2 concepts separately, but they're kind of linked in a sense. So I think the first point for all of us to recognize, and I think which we realize, is that the rate determining effect of the impact of a spinal cord injury is the primary mechanical damage. The worse the damage, the worse the primary mechanical damage, the less likely that there will be improvement either spontaneously or with surgical intervention. And the reason that the outcomes are better with an incomplete let's say spinal cord injury is that you have an underlying substrate that will facilitate greater recovery. Having said that, even when patients, let's say, don't change their Asia grade, you have the opportunity to recover motor levels. And I think that's an important take-home message, from this. What is the impact on the secondary injury? Well, the secondary injury contributes perhaps 10 to 20% to the ultimate pathophysiology. It's what we can target. But realistically, let's say if we look at surgical intervention, or if we look at, let's say, drugs to attenuate inflammation like with methylprednisolone, the effects will vary depending on the type of injury. But overall, we're still going to be looking at effects that perhaps can be viewed as somewhat modest. So the effect of surgical intervention, based on our Lancet article and based on the systematic reviews, is around 4 to 5 motor points. This, interestingly, is also similar to the effect seen with methylprednisolone, just FYI. And the original thoughts were, oh, these effects are so small, they don't matter. But that's not necessarily true because it depends on the patient, et cetera. So let's say a cervical patient, 4 to 5 motor points could be a pretty big deal because it could result in enhanced hand and upper extremity function, for example. So I would say that, and the other point I'll just make with methylprednisolone is the concerns that were raised, let's say around the safety of the drug, are probably no longer valid. This is we're in the 21st century. Our ability to manage medical complications now is so much better than it was 20, 30 years ago. And we have a paper actually that we'll be presenting at the upcoming ISCOS meeting in September showing that the complication rates actually with corticosteroids are actually reduced. And, again, suggesting potential beneficial effects, but in subsets of these patients. I think kind of one of the biggest challenges that all of us face, and probably many people on this webinar, relates to the systems of care. And it's probably quite difficult often to get patients to your centers within the first 24 hours. And I think, so a couple of points here. One is I think that we have an opportunity to look at the systems of care and what can we do to enhance systems of care, and not just in high-income countries, but also in low and middle-income countries. That's one point. The second point is that let's say that a patient does arrive at your center 2 or 3 days after the injury in a more delayed fashion. It's still better to operate than to not operate, okay? Because, although maybe it's not optimal, it's still better because you can get the patient mobilized faster. There still is a potential opportunity to get some recovery of function. I'm often asked that question. So maybe I'll just pause there, but I think Professor Parthiban's brought up, some very important points for discussion.
Thank you, professors. Any more questions, contributions?
There are some questions in the chat, Salvador.
Let me check our chat.
There was a point that was raised by Dr. Caceres. I hope I pronounced your name correctly, which I answered in the chat. But this is just around, there's still groups not convinced of the benefits of early intervention in terms of disability. Look, I acknowledge the fact that there's groups around the world that still don't necessarily buy into even the role of surgery. I was just speaking with a group that were wondering, why are we even operating on patients? And, I think that the landscape has changed. We have much better assessments of stability, and stability surgical techniques have improved. And in terms of the role and timing, I think that, again, if you can get enhanced neurologic recovery, there is very good evidence that it's going to improve quality of life and function. So you can, for example, look at the impact of enhanced motor recovery in the upper extremity on the spinal cord independence measure, the SCIM, and patients have more function. And if you look at the SF-36, health-related quality of life, they rate their quality of life as better. So that's pretty important, I think. And one of the things I have learned from patients is that small effects matter. And I remember we had a patient that was involved in our discussions in the 2017 guidelines, and we were debating the effect of methylprednisolone around, okay, what is the minimal important difference? And what this person said to us, he said, if I can move my finger, I can operate an electrical appliance, a smartphone, and I can have much greater independence. And that was quite impactful for all of us. And so I think realistically, small effects matter. But what I would say is that all of these guidelines are guidelines. And the importance of these webinars, and I want to again thank Dr. Zalali and the leadership here of the WFNS, Dr. Rubiano and others, for putting this together, because is one thing for, you know, Dr. Fehlings and team to write these nice guidelines and these articles and stuff, but how do we implement this, right? How do we actually practically do this? And this still requires tremendous judgment on the part of the surgeons, right? And these are just guidelines. They're there to guide your management, right? And I think as we move forward collectively, we need to think about, okay, how do we raise the bar to enhance this? And at a personal level, I think this is why I feel the WFNS is so important in terms of kind of moving this forward, you know, at the international level. And again, I really want to convey my appreciation, very, very deep appreciation for the leadership in the WFNS for putting webinars like this together and for showing leadership here.
Thank you, Professor. We have a question here from Dr. Pascal from Egypt about early decompression. You mean decompressive laminectomy alone or add dura augmentation?
Yeah, so this gets to the technique of decompression. So again, you know, basic surgical principles arise. So a closed reduction of a fracture dislocation is a technique to achieve decompression. We do recognize that the cord swells after injury. And so I think it's, let's say, in the setting of a bilateral facet dislocation, if you can get the facets reduced, then I think adding a stabilization and then a decompression would be quite helpful. And I think doing a laminectomy with a stabilization, intraoperative ultrasound, which I think is more and more available, is a nice intraoperative technique to assess the quality of the decompression. But you know, if there's a disc herniation anteriorly, you know, an ACDF, that may be sufficient. But I think it depends on where the decompression, on where the compressive pathology lies.
Thank you, Professor. Professor Rubiano, you raise your hand.
Yeah, thank you. I think this discussion is really important and critical. We have been going over every one of the steps for the management of the patient. We have facts now that pre-hospital care is not widely available in many regions of the world. We have facts now that there are so many heterogeneity regarding the emergency care of these patients. And we have facts now that as early as possible, the surgery is beneficial from the patient. I just want to give or have this question for Professor Fehlings, Parthiban, and also for Professor Uma, in order to have the different perspectives, because when we have the first iteration for the bootstrap spine, we have this specific question that is very critical and is recorded of the context. In many regions of the world, you have the possibility to have early imaging of these patients, not all the time and not free sometimes. Some families need to pay for it, but you have the first view of the patient that needs or can beneficiate for early surgery. But what happens is in many regions of the world, the hardware and the system for immobilization is not available in the first, 48 hours or something like that. So the critical question is, if you have a patient that have indication for decompression, but you don't have how to stabilize that, what is your perspective of what to do in this specific case? So I want to have the question for the three of you.
I'd like to defer to my colleagues. I think I've spoken quite a bit. I'd like to be very interested in the perspectives of my colleagues, and then perhaps I can add a few comments as well.
Professor Uma?
Thank you. That's an interesting question. So from a global perspective or a third world perspective, I think it's a situation we commonly find ourselves in, you know. So a patient arrives at your primary or secondary hospital, and, you know, where we work, imaging, at least basic imaging, is not a problem. Basic, by that I mean, for instance, getting a lateral shoot through X-ray, etc., you know, may not be a problem in the primary or secondary hospitals. And so one can make a determination that here is a patient where there has been a dislocation, where something is necessary. The problem then comes from that point. Transferring the patient to the central hospitals where, further surgery can be done, proper decompressions and fusions can be done. The truth is, there is a serious problem in a country like South Africa, which has got a two-tier system. The system where there is private care for the insured patients, that's not a problem. And so I wouldn't discuss that, because patients who are fortunate to fall in that category will not generally experience the problems which the 85% of patients who don't fall in that category will experience. The truth is, many of these patients will come off second best, because there will be delays in transporting them to hospitals where this decompression and surgery can be done. So for us that work in the central hospitals, we typically will receive the patient in a delayed fashion. And so you have a patient arriving 24, 48, 72 hours later with bifacet dislocation, Asia grade A, etc. And that's what you deal with. So when the patient does arrive, of course, you proceed and do your best in those circumstances, but you're cognizant of the fact that your results are not going to be anywhere as good as they would have been had you seen this patient immediately. So I think the short answer to that question is that as we deal with them as and when they arrive, and we do our best under the circumstances to achieve a decompression, to achieve a fusion, in select cases, a decompression, because once they have arrived at the tertiary center, they will then have all manner of investigations, and one will be able to see exactly to what extent we are dealing with cord swelling or, facet fractures or dislocations. And so the correct treatment can be rendered, but the fact of the delay cannot be erased. So I hope that sort of gives you some insight into what happens in the South African situation.
Thank you, Professor Uma. In Mozambique is the same way. We have the same challenges and the same kind of system. Professor Parthiban?
Yeah, now India is, it has very wide, in some parts we are very advanced. In some areas that we do even have air ambulance. There are in some areas where our patient's reachability is very fast. In some areas it is very slow. You all know about the size of Indian continent, and it's all much different. At the same time, even the hospitals also different. Where I practice, I have all the facilities. For example, that I have MRI, CT, ultrasound, theaters, emergency care, all in one level. So when I speak it from my viewpoint, we will do the best of international standard at the time when the patient arrives. So we do not know how quick the patient comes to us. That's what I was talking about it. So sometimes we get the patient in 2 hours time. Sometimes we get the patient in 8 hours time. So it varies to different time zone for the patient to reach us. But the treatment wise, we follow the international standards. We try to operate the patient as early as possible. It's not only the time, but it's not like some of the developed countries where we have the government sponsor for the treatment. In India, the majority of the patients are they have to pay by themselves. So there are corporate issues. So one has to adjust with all those things. Treatment-wise is the same. In fact, when I was talking to you, I was also discussing about methylprednisolone effects, and we are the one who use methylprednisolone in young patients, eligible patients, because as Michael was talking about it, the so-called complications have come down drastically in the past 15, 20 years because the care has gone up. So the standardized treatment is very, very adapted in my place where I work, but it may not be the same thing in a smaller sector. So it's very difficult for me to say what happens in a 3-tier city in India. Even in 3-tier city in India, there are neurosurgeons who are operating within 24 hours time. So we adapt to the standard of care whatever the developed countries are having. So within you mean the 24 hours time surgery, all investigations together in one single slot. That is your CT scan, your MRI, everything is done in one way. So it all depending on the places where the patient lands in. So I personally feel that we cannot have a strict the regime. It has to be done this way, but a standardization has to be made, and that standard, whenever is possible, has to be applied. That's my view.
Thank you, Professor Parthiban. And Professor Rubiano, what's your experience on that?
No, I just was
Reality.
mentioning this because in many places, and even sometimes in our center, we have patients, we have the team there, but the hardware is not available on time for the first 24 hours. So the question is, if you have the possibility of decompress the patient, but you don't have the possibility to fusion it, what will be the best approach? Because you are right to this position. So I am in the position of maybe these patients need to be offered to the early decompression, but it all depends on what is the postoperative care that you are going to have over that patient, because sometimes managing patients that does not have fusion is a very complicated case, and you can generate more complications in a patient that you operate with early decompression, but you don't have the fusion techniques possibility. So early also. So that's why I am asking here, because this point was very critical when we were doing the stratification for management of care, because this condition is very common in many regions of the world. So I want to hear Michael's approach related to that.
So,
Links.
Can I ask something?
Yeah.
Sergio? Yeah,
No,
actually,
I was
first
giving-
of all, I thank all the speakers. They were really very nice talks. Dr. Andres Rubiano, Dr. John Uma, Jyoti Parthiban, and lastly, Michael Fehlings has given very nice messages. I find two take-home messages here. We must operate as soon as possible if we see a spinal cord injury patient. This is one message. The other one is the intensive care management must also be a part of our routine. Probably in many places, especially in limit countries, it is lacking. And we don't that much monitor the blood pressure levels. So we must then take on messages that intensive care is necessary and early surgery is necessary. Do you have any other comments? Thank you.
I think that's an excellent summary. Time is fine.
Not able to hear. You're not able to hear?
Let me try again. Are you able to hear now?
Yep.
Yeah, I think that Mehmet's take-home messages are excellent. I think that what I would add to this is that time is fine, that we need to advocate for enhanced care pathways in all sectors of the world, and to look at practical ways to implement these principles, not just in high-income countries, but in low and middle-income countries as well. So I think that's one of our challenges. I think to Andres's point, I would be hesitant to do a decompression without a stabilization. I think the nursing care would be extremely difficult, because if you do the decompression, you have destabilized the spine and you potentially risk further injury. So I would discourage that. I think it would be better to wait until you have the materials in place. And I'm increasingly aware of some of the challenges that my dear colleagues around the world face, and it's my goal to try to create the arguments to enhance the infrastructure that you have to provide care for your patients. And my hope is that the evidence that we provide, let's say through the guidelines, would, I think, allow us to make those arguments. And then potentially, you know, through international bodies such as the WFNS, if we come up with consensus statements, you know, this will help. And then I think also, you know, trying to, you know, address these points. And Dr. Uma, you might be interested to know that I've been invited to South Africa in August to attend the neurosurgical conference there. So I will be speaking on some of these topics, and I look forward to interacting with yourself and other colleagues in South Africa.
Thank you. Looking forward to seeing you. Thank you.
Yes, there was a question from a participant telling that shall we do a laminectomy for decompression? It's not the answer. I think we must stabilize and make good realignment of the spine. This is decompression, actually. It's an old-fashioned thing, telling that laminectomy alone is enough. It's not that. Thank you. I think we can complete our session here. Sergio, do you want to add something else?
Yes, no, just to thank Professor Rubiano, Professor Parthiban, Professor Oma, and Professor Fehlings for these excellent presentations. Very interesting discussion, nice topics. I think we still have a lot of issues that are controversial, but the important thing is to discuss and to clarify when to do the things on the best interest of our patients. That's it. And thank you for the opportunity of moderating this table to Professor Zeleli.
I thank also the participants.
And the participants, of course.
Yeah.
The most important
Thank
ones.
you.
Thank you.
Thank you and goodbye.
Thank you.
Thank you. Nice to see you.
Goodbye.
Bye.